Hi, good afternoon. My name is Ebony Grant, and I'm a nurse practitioner student here to do a head-to-toe assessment on you. Is that okay?
Yeah.
Great. Can you just first start by telling me your first and last name?
Kanasia Winter.
Good. And your date of birth?
February 28, 1993.
Perfect. Okay. So the first thing we're going to do is some hand hygiene. Okay. All right. So the first part of your assessment is the skin assessment. So I'm just going to look at the patient and assess the patient's skin, looking for any bruises, lumps, scarring, any petechiae or any other lesions or abnormal skin findings, and none of that is present. Patient's skin is warm to touch and skin turgor is normal. The next thing we're going to look at is the patient's head and inspect the patient's skull, palpating for any kind of indentations or past head trauma. We're also looking at the patient's hair and the scalp, looking for any kind of rashes or hair loss, and none of that is evident. The next thing we're going to move on to are the patient's eyes. So do you mind taking off your glasses for me?
Yeah, sure.
Perfect. Okay, just look straight ahead at the wall. All right, just from looking at the patient, I can see that the patient's eyes are symmetrical. And now what I'm going to do is pull down the patient's left lower lash line and just inspect the conjunctiva, which is pink in color, and inspect the sclera, which is white in color. The next thing I'm going to do is have the patient continue to stare behind me at the wall, and then I'm just going to bring this object closer to them. Now you can focus on this object, and as the patient focused from the wall to the object, I saw that her pupils went from dilated to constriction, and this is positive of accommodation. The next thing I'm going to test is convergence. So I'm going to have the patient continue to look at this object and bring it closer to their face. Good. And the patient's eyes came together, which is positive or a good sign, a normal convergence. Also part of the eye exam is normally testing for cranial nerve 2, which is the optic nerve, and this is done by using a Snellen chart to test visual acuity. The next thing we'll check for is pupillary response. So with my pen light, I'm just going to have the patient look at the wall behind me, and I'm going to shine a light into the patient's eyes. Okay, and then to the other eye. Good, and pupils will equal around and react to light, which is normal. So I'm going to have the patients continue to look at the wall, and I'm just going to shine a light generally in the patient's direction. Okay, and I can see that the pupils are symmetrical, and there's no kind of deviation when looking at the patient's eyes, and that's the corneal light reflex. The last part of the eye exam, another part of the eye exam is testing for the corneal blink reflex. So normally you would use a cotton wasp of some sort and have the patient kind of look up toward the ceiling, and then I would use the cotton wasp and rub it against the patient's sclera, and if the patient blinks, that means that the corneal blink reflex is normal. Another part of the eye exam is testing the cranial nerves 3, 4, and 6, which are the oculomotor, trochlear, and the abducens nerves, and this is testing for the extraocular movement. So I'm going to stand on this side. You can just face forward, and you're just going to follow my finger with your eyes in each direction, okay? So you're going to go up. Good. Good. So extraocular movements are intact for the patient, which is great. So the next thing we're going to move on to is the patient's ear. So when inspecting the ear, we're going to, especially in an adult patient, we're going to have the ear and pull it away and back from the patient gently. Be sure to not hurt the patient. And when inspecting the ear with an otoscope, we'll be looking at the external structures and the internal structures. Internally, we'll be looking at the eardrum, checking for any kind of swelling, any kind of discharge, or erythema. And a normal eardrum should appear to be pearly gray in color. Another part of the hearing test is testing for how well the patient can hear. So I'm going to whisper in the patient's ear, and you're just going to tell me what I said to you. Repeat back to what I said.
The sky is blue.
Perfect. Another part of testing for hearing is a test known as the Weber test, and this test is done by using a tuning fork. I'm just going to pretend this is a tuning fork. You would hit it and then place it up on top and in the middle of the patient's head, and I'll ask the patient if they hear the sounds equally in each ear, and if they do, then that is indicative of symmetrical hearing, and that's a good sign for the hearing conduction. The next thing we're going to do is we're going to move on to the nose, and we're going to just visually look and inspect the patient's nose and the external nares. We're going to palpate, move forward, palpate the patient's nose, feeling for any deviation. I would also use a light to look at the internal structures of the nose and the nares, looking at the turbinates in the nasal mucosa, checking for any kind of like discharge or any other nasal like abnormality. The next part of the nose exam is checking for the patient's sense of smell. So what I'm going to do is I'm going to have the patient occlude one nostril, and you're just going to tell me what this smells like.
Peaches.
Good. And then you're going to occlude the other nostril and tell me what that smells like.
Oranges.
Great. Awesome. All right. So, and that was testing for the olfactory nerve, which is cranial nerve 1. So moving on, we're going to check your sinuses, the patient's sinuses. So I'm just going to palpate the frontal sinus and tell me if you feel any pain or tenderness.
No.
Good. And the maxillary, any pain or tenderness?
No.
Good. After that, we're going to check the trigeminal nerve, which is cranial nerve 5. So I'm going to have the patient clench her teeth. So clench your teeth. Good. And as I palpate, I can feel that the strength of both sides of the mouth are equal, strong, and symmetrical. Another cranial nerve I'm going to test is going back to trigeminal nerve, I'm going to test using a small object, and you're going to tell me if it feels dull or pointy or sharp. What does this feel like?
Dull.
Okay. And this?
Sharp.
Okay. How about here?
Dull.
Okay. And this?
Sharp.
Okay, perfect. Findings are normal for the trigeminal cranial nerve. The next nerve cranial nerve we're going to assess is the facial nerve, which is cranial nerve 7. So I'm going to have the patient do a big smile. Good. Frown. Good. And puff your cheeks out. Good. And lift your eyebrows up. Perfect. So you can rest your face, relax your face. All right. The next thing we're going to assess is the oral cavity, or just the mouth. So I'm just going to use my light and just inspect the patient's outer. You can have your mouth closed first. Just the lips. Okay, you can open your mouth and inspect the internal structures of the mouth, looking at the tongue, the hard and soft palate, looking at the teeth and other dental structures. Perfect. Can you make the sound ah for me?
Ah.
All right. When the patient made the sound, that was testing for a cranial nerve. Cranial nerve 9 and 10, which is for the glossopharyngeal and the vagus cranial nerves. And when the patient said something, there was no indication of any hoarseness or voice abnormality. We're also going to test cranial nerve 12, which is the hypoglossal nerve. So I'm just going to have the patient stick your tongue out forward. Good. You can move it left to right. Good. You're going to close your mouth, and then you're going to stick your tongue against your cheek. Good. Good. All right. So from that exam, I can see that the patient's tongue is strong, and the movements are symmetrical on each side of the mouth. So after that, we are going to test the patient's or look at the patient's neck. So I'm going to look at the trachea and palpate down, feeling for any kind of deviations. I'm going to come to the back of the patient and have the patient tilt her neck back, and I'm going to palpate the thyroid and check for any thyroid enlargement. The next thing I'm going to do is feel for the carotid pulses. So I'm going to check the pulse on each side individually. Make sure you remember that. Good. And the carotid pulses are present and strong. Next, I'm going to use my stethoscope. And I'm going to use the diaphragm to listen to any carotid bruits. Great. And there are no bruits present. Okay. So the next thing I'm going to move on to is the thorax. So the first part, or the lung portion. And with the first thing we're going to do is inspect the patient. And from looking at the patient, I can see that there's no labored breathing or difficulty breathing. Her chest is symmetrical. Her AP diameter seems as if it's 1 to 2. And I'm just going to have the patient drop your legs for me. I'm going to have the patient sit forward. I'm just going to have my hands here under the breast, and just have the patient take a breath for me. Good. You can breathe out. Good. Chest expansion is normal and symmetrical. So now I'm going to have the patient kind of flip around and face the wall. While I did the chest expansion, I also felt for any kind of masses on the chest. I'm just going to move the patient's hair to the front. Okay, and I'm just going to also palpate and inspect for any kind of palpable masses that could be present. I'm also going to do a test called testing for tactile fremitus. So I'm going to have the patient say 99 out loud and just continue to say it as I move from one area to the next. So say 99.
99.
Okay.
99.
Good.
99.
Good.
99.
Great. Tactile fremitus is a test used to test for any kind of consolidation or liquid that could be in the lungs. And if there's decreased tactile fremitus, that means that there could be some kind of extra air, or a patient could have a history of COPD or like emphysema. So while the patient is facing forward or the opposite direction, I'm going to take this time to listen to the patient's breath sounds using the diaphragm of my stethoscope. So we're going to start on the left upper lobe. Take a deep breath. Good. Right upper lobe, deep breath. Good. Right middle lobe, deep breath. And left lower lobe, deep breath. And lastly, right lower lobe, deep breath. Okay, so what you're going to do now is you're going to say the word E.
E.
All right, and that test is testing for egophony. Usually, egophony is testing also for any kind of consolidation or fluid that would be in the patient's lungs, and egophony test was negative for the patient. So now I'm just going to have the patient turn back around toward me. Perfect. And I'm just going to finish up my chest exam, listening to the breath sounds on the right side. Deep breath. Good. And then the left side. Deep breath. Okay. And all breath sounds are clear. So now that I have this patient in this front sitting position, we're just going to move on to the cardiac portion. So now I'm going to use my stethoscope once again, using the diaphragm portion of my stethoscope, and listen to different heart sounds. So we're going to do the aortic, which is at the second intercostal space of left external border. Then we're going to do the pulmonic, which is second intercostal space, right external border. Then we're going to move down to the fourth intercostal space, where we'll hear the tricuspid heart sound, which is also right of the sternal border. And lastly, we're going to listen to the mitral heart sound, which is at the fifth intercostal space and midclavicular line. Okay, so all heart sounds are normal. I'm just now going to have the patient lie laterally onto her left side with her arm raised above her head, so you can get into that position. Yeah, turn that way. Yep. Good. And with the bell portion of my stethoscope, I'm just going to listen for S3 sound, which is an abnormal sound, or any other murmurs. Okay, great. And none of those sounds are present. So the patient can come back onto her back in a supine position. Can you swoosh down a little bit? Perfect. So now we're just going to move on, and we're going to assess the patient's pulses. So can you flip your hands like that? Perfect. So here we're going to be testing for the radial pulse bilaterally, which are strong and present. Good. Next, we're going to test for the popliteal pulses bilaterally, which are strong and present. And lastly, we're testing for the dorsalis pedis pulses, which are strong and present bilaterally. While we're down here at the feet, I'm going to be checking the lower extremities for any kind of pitting edema or impaired circulation, and none of that is present. I'm just going to come back up to the patient and just lift her shirt up slightly just to see her abdomen. And the first thing I'll do with the abdominal assessment is just inspect it for any kind of like scarring or bruising or anything like that, and also check for distension. After I check for distension, I'm going to be auscultating. So I'm going to use my stethoscope once again and listen with the diaphragm of the stethoscope. And we're going to listen in each quadrant for positive vowel sounds. Good. And there are vowel sounds present. While listening, we're also going to listen for any aortic, any renal, or any iliac bruise, and none of that is present as well. All right, the next thing we're going to move on to is percussion. So I'm going to percuss the patient's abdomen from left to right. And what I'm hearing right now is a tympanic sound. But as I move up toward the right side, upper side of the patient's abdomen, I heard sounds of dullness. And this is most likely because this is where the liver is located. The next thing I'm going to do while I'm next to the liver is palpate the liver. So I'm going to have the patient take a nice deep breath in. Good. And I'm just going to push down. And do you feel any pain as I push down? Good. And you can breathe out. Perfect. And this is my assessment just now was for testing the Murphy sign. And if the patient felt pain when I pressed down, that could be indicative of like an acute cholecystitis, but that's negative. The next thing I'm going to do is just continue to palpate the patient's abdomen, checking for any pain or tenderness. Is any of that present?
No.
Okay, great. I'm also going to palpate your kidneys on each side. Is there any pain when I palpate?
No.
Great. I'm just going to come down to the right lower quadrant of your belly, and I'm going to press down and then let go quickly. Once I let go quickly, just let me know if you feel any pain. Okay? Any pain?
No pain.
Great. Awesome. All right, and that is negative rebound tenderness. And that could be indicative of like a appendicitis if it were positive. Lastly, we're going to test the psoas sign, and I'm going to have the patient lift her right leg just up toward the ceiling. While pressing down, keep going, press down and get resistance. Perfect. Do you feel any pain in your abdomen when I do that?
No.
Perfect. So there's a negative psoas sign. And lastly, I'm just going to have the patient sit up. Good. Face the wall. Perfect. I'm just going to come to the back of you, and I'm just going to gently tap behind you and tell me if you feel any pain or tenderness. Any pain?
No.
Good. And that's negative CVA tenderness. And that concludes our physical exam. So thank you for your participation.
No problem.
All right.